A patient presents with diffuse, migrating joint pain. Knees ache in the morning, hands swell by the afternoon, and the lower back stiffens overnight. To the untrained eye, this presentation is a chaotic map of overlapping symptoms. Clinical rheumatology, however, relies on stripping away that chaos. Identifying the exact autoimmune or mechanical failure driving the pain is an exercise in rigorous, algorithmic deduction. We can build a clinical reckoner, a diagnostic matrix, to process these subjective complaints into objective data. Every patient history is filtered through two primary dimensions: the chronicity, or timescale of the symptoms, and their spatial distribution across the body. We then refine this base matrix by isolating specific physical biomechanics and applying validated point-based scoring criteria. This algorithmic framework organizes diffuse clinical signals into a structured pathway designed to identify specific joint pathologies before they result in irreversible damage. This split-screen graphic illustrates the primary bifurcation in our decision tree, distinguishing inflammatory autoimmune disease from the non-inflammatory, mechanical wear of osteoarthritis. The most critical differentiator is the duration of morning stiffness. Notice the strict thresholds. Stiffness lasting over an hour indicates fire, while stiffness resolving in under 30 minutes indicates friction. Prolonged stiffness points to the gel phenomenon. During periods of rest, inflammatory synovial fluids physically thicken, requiring prolonged movement to disperse the localized autoimmune activity. Conversely, the brief stiffness characteristic of structural joint wear resolves rapidly once the mechanical components are physically mobilized. The second historical discriminator operates on how that pain responds to physical movement. Inflammatory joint pain actually decreases with mild activity. The movement helps flush the accumulated inflammatory mediators from the joint space. Mechanical pain follows the opposite rule. It actively worsens with physical use and predictably improves with rest. Capturing these specific historical markers early prevents catastrophic clinical errors, like prescribing heavy immunosuppressive therapies for simple cartilage deterioration. This flowchart maps the spatial and temporal distribution of the disease, acting as the next filter in our algorithm. We establish a strict joint count threshold to separate monoarthritis and oligoarthritis, affecting 1 to 3 joints, from polyarthritis, which affects 4 or more. If a patient presents with sudden, intense swelling in a single joint, we follow the acute monoarthritis pathway. This exact quadrant is highly indicative of crystal deposition, like gout, or a destructive infectious arthritis requiring immediate intervention. Shifting to the opposite extreme of the matrix, we evaluate chronic polyarthritis. Here, symmetry dictates the differential. Rheumatoid arthritis typically presents with symmetrical joint affection, while osteoarthritis damage is highly asymmetrical. Looking closely at the digits reveals a definitive rule. RA aggressively attacks the proximal joints, the MCPs and PIPs, but distinctly spares the distal interphalangeal joints at the fingertips. Osteoarthritis does not. Precise spatial mapping effectively narrows a differential of dozens of potential diseases down to 2 or 3 prime suspects before the physician touches the patient. We now pivot the algorithm from patient history to targeted regional physical examination. The hand serves as our primary biomechanical canvas, exposing the specific tendon failures driven by underlying rheumatological disease. Early-stage disease presents as soft tissue spindling around the joints. Left unchecked, this progresses to severe, irreversible structural imbalances. This 3D rig demonstrates the exact structural mechanics of a swan neck deformity. Tension forces the proximal joint into hyperextension, pulling the distal joint into forced flexion. Contrast this with the boutonniere deformity. Here, the central slip of the extensor tendon physically disrupts, causing the joint alignment to collapse in the exact opposite direction. We then shift this biomechanical examination from the peripheral joints to the axial skeleton. This anatomical model demonstrates the modified Schober's test, designed to quantify structural restriction in the lumbar spine. We establish baseline anatomical markers relative to the posterior superior iliac spine, marking a 15-centimeter segment. The patient is instructed to bend forward maximally. A healthy spine will stretch these markers apart. A total expansion measuring less than 5 centimeters indicates abnormal, severe restriction. When the caliper locks below the healthy threshold, we isolate the specific biomechanical failure characteristic of ankylosing spondylitis. These specialized physical exams isolate the specific mechanical failures driving the disease, providing objective data that often remains hidden during history-taking alone. Rheumatological conditions are not confined to the skeleton. The diagnostic matrix must account for multisystemic pathology. This body map highlights extra-articular manifestations. We must search for these biological markers to confirm overlapping symptom profiles. Diagnosing a complex condition like systemic lupus erythematosus requires systemic triangulation. The presence of a malar rash across the face, painless oral ulcers, and measurable renal involvement strongly pivots the differential towards SLE. We contrast this profile with the extra-articular anchors associated with advanced rheumatoid arthritis. In severe cases of RA, the inflammation migrates, forming hard subcutaneous nodules and causing interstitial lung disease. When localized joint symptoms remain ambiguous, these systemic markers act as the definitive tiebreakers. The final objective of the clinical reckoner is converting these physical findings into mathematical certainty. This digital interface represents the 2010 ACR-EULAR classification criteria for rheumatoid arthritis. This matrix applies strict, weighted values to our gathered data. Extensive small joint involvement logs 3 points. Highly positive autoantibodies add another 3. Abnormal acute phase reactants push the total score to 7, crossing the diagnostic threshold of 6 to confirm rheumatoid arthritis. This mathematical approach extends past the initial diagnosis and directly informs long-term disease management. Clinicians rely on indices like the DAS-28, the Disease Activity Score, to track remission states and dictate aggressive systemic therapy changes. By synthesizing history, spatial distribution, and biomechanics into weighted criteria, clinicians achieve the diagnostic certainty required to dictate the physical trajectory of the patient's life.